Okay, so it looks like we are live.
Yeah, so good afternoon, everyone, and welcome to this week's RCC Roundtable. So glad to see everyone and to our speakers and our panelists today. Thank you all so much for taking time out of your busy schedules to be here with us today. Today's topic is all about sexual trauma and the medical world. So just like, the weeks before, for those of you who are joining us live, make sure that if you want to be a part of the conversation, and we hope that you will place all of your comments and your questions in the chat, and we will do our best to address them. So just like, any other roundtable, we're going to jump right in, and we have a special facilitator today. Abby is going to go ahead and get us discussing this very powerful topic.
Yeah, well, do we want to do a quick intro just to
Yeah.
make sure everybody... Okay, so I'm Abby. I was previously a victim advocate with the Rape Crisis Center for 2 years, and just recently I switched into the 2-on-1 role as a resource specialist. But I want to give all of our panelists a chance just to kind of introduce themselves and say hi, and then we'll jump right in. All right, Candice, do you want to start?
Yes, I'm Candice Selwyn. I am a research assistant professor in the College of Nursing at the University of South Alabama, although I am a psychologist by discipline, and I specialize in working with women who have experienced interpersonal violence, such as sexual trauma.
Thank you. And Ashley?
I'm Ashley Marass. I'm the chair of the Maternal Child Health Department at the College of Nursing at USA. I'm associate professor there, and by trade, I'm a pediatric nurse practitioner and SANE A certified, and my specialty in pediatrics is adolescent care.
Wonderful. Daphne?
Hey, I'm Daphne Hutto, and I'm an instructor in the College of Nursing Maternal Child Department. And I'm a women's health nurse practitioner by trade. I currently practice a couple of days a week at Bay Area Physicians for Women, and I'm in the process of getting my SANE certification.
Awesome. Great. And Angela?
My name is Angela Mosley Johnson. I am a fourth-year medical student at the University of South Alabama College of Medicine. I recently matched into OBGYN at the University of South Alabama, so I'll be here for another 4 years as a resident physician in OBGYN.
And she's also one of our great volunteer advocates, so don't forget that part. She's a great asset to the team. And good afternoon, everyone. My name is Kelsey Bryant. I'm the Prevention Education Coordinator with Lifeline's Counseling Services and the Rape Crisis Center. And we have another panelist that is just joining us. So we're going to go ahead and get her to introduce herself, and then we'll jump right into this great discussion. Amisha, are you there?
Yes, I'm here.
All right, go ahead and give us a quick introduction, and good afternoon and welcome.
Hello, everyone. My name is Amisha Bush Taylor, and I've been a family nurse practitioner for about a little over 10 years, and I've been a registered nurse for about 25 years.
Thank you so much for being here.
Yeah, thank you so much for joining us. And so we'll jump right in. And so obviously this is for anybody, just jump right in. But how do you define trauma-informed care, and how do you see it used in your work?
The sexual trauma, or just trauma in general?
Well, yeah, we're definitely going to get into sexual trauma, but yeah, how do you see trauma-informed care, in sexual assault work, or in, in your everyday work when working with clients? And it doesn't necessarily have to be just sexual assault, because we know trauma-informed care can benefit anyone in any circumstance. And so yeah, hopefully that helps clarify a little bit.
Well, to me, trauma-informed care is really all about seeing the person in front of you in a holistic context. So taking into account their life experiences, particularly those that may have been traumatic in nature, when understanding the person sitting in front of you. So the way that they may be behaving, the symptoms that they might be presenting with, understanding that there can be some underlying events or experiences that might be contributing to, your interaction with them. And also try to emphasize that, a lot of times we rightfully so want to focus on the patients that we're treating, But trauma-informed care also encompasses how we care for one another as providers, and that we can only provide the amount of care that we're willing to kind of give to each other, and that amount of grace and compassion.
Absolutely. And I'm glad you said that about not just patient care, but also coworker care, because that's a big part of how we experience our jobs is, both of those sides. Yeah, absolutely. Yeah. Anybody else see it used in their work, or how they see it used in their work?
I think on my end, we probably need to develop something that's a little more straightforward, I would say, because a lot of times it get overlooked in primary care unless the patient themselves bring it up.
Okay. Gotcha. Yeah, and that actually kind of leads into my next question perfectly, actually, about how often do you speak with your patients or clients about their sexual history, and especially history of sexual violence? And is it a part of normal screening with new patients?
Well, I can speak to that. In the adolescent world, it's very important to assess adolescent sexual health. So in turn, that's always a question that I will ask them about, if they're sexually active, and also if that's something that they wanted, or, that they were consensual with, and that kind of thing. So we do go through, a lot of those questions in the adolescent world, because a lot of times if you don't ask specifically, you won't know. And it kind of goes back to the trauma-informed care question that you had before, is that, you may not understand why a patient is acting the way that they are. And if you don't ask the question, you may not know, because they don't want to tell you. They might be embarrassed, or they may not want to tell the story. They may think that you'll think bad of them, or any of those things go through their mind, especially in our adolescent patients. And so that's why I make a point to every time ask the specific question. so that way, in hopes to get an honest answer. So.
Yeah.
And just to add to that, from like the side of like medical education. So we're taught from like the very beginning, once we're interviewing a patient, to, ask questions about their sexual health, about sexual history, about a history of any type of sexual abuse, child abuse, anything like that. Now, what happens with that information once it's given is kind of, I guess, taught to be kind of up to like us, how we interpret it and how we're compassionate with the patient. So I can't really, speak to that from like, having a lot of experience from that standpoint. But we are taught, like, as clinicians, to like, ask about that information, and so we know, and kind of what to screen for, and kind of where to go from there. So.
Well, and I think from assistant professor perspective too, and like what you were talking about, Angela, is that I think it's really important to start at that point, teaching providers and clinicians to include that, because it can be, I know with my BSN students that are just starting out in patient care, it can be an awkward conversation to have with a patient. And but it's so important that I think the earlier and the more we teach our clinicians coming in about how important it is, and how important how it affects the entire patient, not just their sexual health, I think that really can help as far as getting new doctors and nurses and everybody out,
Right.
Yeah.
I'm glad that you mentioned that, Ashley, about how it can affect the whole person, not just their sexual health, because I do see a lot of variation in how often providers ask this question depending on their setting. So I know that Amisha mentioned earlier that, this often is not used in primary care, and that's because oftentimes their presenting problem is not directly related. But when I talk to providers, especially in primary care, I try to make the point that you're treating these patients whether you know it or not. And so wouldn't you rather know? Wouldn't you like to have more information about their history, again, to understand them better and the presenting complaints that they have?
Well, I think
I will add, I'm sorry.
Oh, I'm sorry, Amisha, you go ahead.
I will add that I agree with Ashley, and I think that was Candice, that it is seen more in the adolescents because that's one of their screening processes. But we tend to fall short, I think, on the adult side, primary care level. And so just like we do the depression screen for everyone, I think we need to start implementing that and incorporating that into a screening process as well, that we can address different things, because we already know the percentage of the population, especially women, although men are overlooked population as well, and it does happen with them.
Yes.
We do tend to forget the high percentage, especially in the different ethnic groups that it affects.
And I'll say I agree with Amisha, being, mainly OBGYN focused. In the adolescent world, it's more, we think about it more. And when we ask about their sexual health, did you consent to this? Did you want this? But on the adult side, and I even after I went through the talking points, I even started talking to my medical assistants and my nurses. And I was like, is this on our new patient forums? Do y'all ever ask about this? What do we do? And they're all like, no, it's not really until they come in and they bring it up. And like Candice said, we have to kind of have a relationship with them. But we always need to have it in the back of our head that they're there and we're supposed to be addressing the whole person. So I'll say on the adolescent side, I think about it more if I'm treating an adolescent, but not as much with an adult.
Can I jump in and ask why that's omitted at that level? Does anybody know why that's been omitted? Is it just uncomfortable, or is it just, you're asking it, while they're adolescents, but why is it not asked when they're adults?
I can tell you, go ahead, please.
I would say that I think we're so focused on the other primary diseases that they're coming in with that it's not being brought to our attention. So we need to do a better job on that in primary care.
Yeah.
There's also been some studies that try to understand provider barriers to screening for sexual assault. And what they have found is, commonly cited reasons are not enough time because they have such limited time with their patients, but also there is personal discomfort, not knowing how to respond if a patient does disclose a sexual assault history, and not wanting to upset the patient is a really common response. But what we have found is if you ask patients, they actually want their provider to ask them. They're not really going to disclose it voluntarily, usually, is what we found. But if asked, most of them are willing to, to disclose to their provider, and they think it's important that their provider know.
Okay.
And I think too, and I'm not in the adult world, but I think we as providers and just society in general assume that an adult is sexually active. So that topic doesn't tend to come up. Like when I go in to my doctor, unless I'm going to my OBGYN, which is a specialty, but I don't go there very often. So, if I go to my family doctor for a sinus infection, he doesn't ask me if I'm sexually active right now because I have 3 kids and that kind of thing. So I think not that that's a good reason, that I think that it should be screened every time, but I think it's just kind of looked over because, she's a married with kids adult. She's sexually active, but instead it should be more, how's everything going? Is there anything going on? Do you feel safe at home? Those kinds of things, but I think it just gets omitted for all the reasons that Amisha and Candice said, just because it's not as big of a talking point as it is for adolescents. Like one of the first things I say when they come in is, how's it going? You have a girlfriend, you have a boyfriend, what's going, so I think it's just one of those topics that kind of is looked over, unfortunately.
And we have a comment from Facebook. Laurie says, great point about the screening process.
Yeah, and I guess that kind of gets back to not necessarily just about asking specifically about sexual history, but really back to the first question about trauma-informed care and how really, that could maybe more easily play a factor into all different types of medical visits as opposed to just, asking about sexual history. Because, like Ashley said, if I'm going to this, to get my sinuses checked, that may not be a question that comes up, but the topic of trauma-informed care and how that doctor then treats you could definitely play a huge factor in your overall experience there, without them maybe not necessarily having to know what maybe your sexual violence history might be. But yeah, and actually that all of that does kind of lead us to you know, how, and I'm just kind of curious when you all do find out, or when you physicians do find out when someone has a history of sexual trauma, how does that change things? Because I know it was either Ashley or Candice mentioned that oftentimes physicians, you know, they don't know how to respond. That becomes the issue. It's like maybe they find out, but they don't know how to respond, or they don't feel comfortable in those situations. And so, you know, when those things are brought up, and especially if I found it, that's so amazing and interesting, Candice, that you said that patients want, you know, doctors to ask about these things. But so I guess then what happens when they do find out? You know, what all are you seeing, you know, after that kind of barrier has been breached?
I'm glad you said that, because we have a Facebook question, and Maggie's question was, once the adult brings it up, where do you go with their care? So we're all in sync. So we're just waiting on somebody to answer.
Well, I will start. We need to know the appropriate place to refer them to. First question we need to ask is if they've had any counseling, or if they feel like they need counseling. Have they spoken to anyone? Was the police or anyone else involved in the incident? Need to find out the extent that it went. And a lot of times we find out, of course, that nothing has been done, and they've kind of buried the feelings and emotions within. And a lot of times once they do that, other symptoms tend to evolve from that, such as like stomach pains and different ailments that tends to come up from that.
Yeah,
with
I
the
totally agree.
undealt with feelings.
Yeah, absolutely.
And I think too, you know, depending on how acute the situation was, would also really drive your care. You know, like Amisha said, we would definitely want to see if they had reported, or if they, you know, had been to counseling. But if it's an acute case, you know, then we would kind of look into doing the exam and things like that. And I think as far as doing taking care of those patients, I think that control and permission is a huge factor in their care. Asking them, is it okay if I do this? Is it getting permission for each new thing that you're doing? Just because a lot of times in those sexual assault situations, they do lose all control. Any abuse situation, any traumatic situation, really. And so I think that as far as performing your care on the patient, that's one of the biggest, most important things to me.
Yeah.
I think with these patients, follow-up is huge also, because, you know, they've come in and they've taken the step to tell you about it. And like Ashley said, you know, your care is kind of driven on, is this acute, or was this years ago and they buried it and now there are other symptoms that have come up. But once you get them to where they need to go, or you know, you provide them with the resources, I think follow up also, though, making sure, you know, are they coming back to see you in a week? Did they miss that appointment? Did you call them a few days later to check on them? Because a lot of times I think just showing them that there is somebody out there that cares, and that you really want them, you know, to get the help they need, and that because they may go home and never go to those appointments that they needed, you know, never follow through with that counseling or whatever.
Is follow-up possible? Like, do you find that in practice you have that ability to consistently follow up with folks?
Oh yeah.
That's awesome.
I mean, because we know how busy everyone is.
Yeah.
So, and we also do follow-ups, of course. And if we are as busy as we are, we know you guys are running as fast as you can. So that was a great question, Abby, because I was thinking that, you know, do you guys even have a moment to follow up? Not that you don't want to,
right, but
just have that time that's built into your day.
I will, but I will say also, it may not be me personally calling them, but like where I work, we have a really good team. So it's, you know, I have my specific medical assistants, my specific nurses, and my patients are very close to them also. So if I realize that they also have a relationship with them, it's okay that they call and just check, hey, just wanted to make sure that you know, went to this appointment or whatever. So we have a really good like team approach to it. So the patient knows that, you know, maybe I'm not in clinic, but they know that somebody's always there that they talked to before and they have a relationship with, and that they can call.
I'll even do a follow-up appointment to just to make sure that, they did go to their counseling appointment. They did take all of their medications that they needed for, any sort of prevention or whatever that they needed. And really just to check in, I just need to see your face. Are you okay? That kind of thing. So sometimes I'll do that too. If I, because some of these patients, it's hard to get on the phone and hard to talk to them again. So sometimes a follow-up visit, you have to do.
Yeah. And especially with you working with adolescents, you may not specifically have to speak with the adolescent themselves, but maybe a parent or a
And
guardian.
that's a whole different topic. Yes. Because, confidentiality and things like that are important with adolescents. And this is a very sensitive topic with them. So that kind of gets into a whole nother topic about talking to the parent versus the adolescent. So, yeah.
Yeah. And
I do know the patients that I've had some follow-ups with, they really appreciate that, especially a simple phone call. Like you say, they want to know that someone cares about them. And it's not just a financial care, it's a care from the heart. So that makes a huge difference in a patient's life.
Absolutely. One of the kind of key phrases from the trauma-informed care framework is healing happens in relationships. And when I'm training with providers, that's something that I really try to emphasize, that it's not even so much about, what you do or who you refer them to, or that they get to that appointment. That is all very important. But when you ask patients what really matters to them, it comes down to like the person in front of them showing concern and compassion for them, that even if they don't follow up or they might not even need counseling, just having that positive response when they're willing to disclose their history is incredibly powerful. And so I think a lot of times a barrier for providers is almost feeling like they need to do more, like I'm not able to do enough, so I don't even want to ask the question, when really asking the question is one of the most important parts, just even opening up that conversation.
Yeah. And we have a question. So how do we go about training or teaching doctors who aren't OBGYNs to start asking these necessary questions, especially for those who don't see OBGYNs? Mm-hmm. I don't know if you had that on your list, Abby, but I think that's a great question.
Yeah, absolutely. Because, like we said, men and even people who don't identify as male or female, people who don't identify as a part of the gender binary, people who, so not everyone is going to go to an OBGYN. And so that is definitely a big group of people that, may not be receiving this type of screening in any way. And so that's a great question, Ginger. Yeah.
Yeah.
So
I think it is a really great question. So in our preclinical years, like we pretty much, no matter what specialty you're going into, like we all have like we call them SP encounters, like standardized patient encounters, where we're taught how to interview a patient, what questions to ask. So technically we're all taught, at the beginning that we should ask these questions. I think it's probably more culture and habit within people's specialty that, kind of things drop off. That, maybe you don't ask the questions because the physicians around you kind of weren't taught to ask questions, or they don't ask the questions. I think there should be continued training like after the preclinical years and in the clinical years. And that was one thing I felt like was lacking in like my medical education and wanting to go into OBGYN, is like what to do in these situations and how to support men and women and children who do go through these situations. And so that's why I decided to volunteer with the Rape Crisis Center. But there's definitely room for it. Absolutely. I think where does it go is probably the biggest question.
Right. It sounds like you're trying to rework a system that's already been set in place for so long. It's a lot of re-education and new generations of people coming through, and more awareness to these types of things and these potentials to reach clients and patients in different ways. Yeah, and which actually, Angela, that really kind of pushes into the next question about, specifically getting into some discussions on like demographics when it comes to care. So just a quick background. So all of this kind of came about this wanting to do this roundtable. I had a baby last May, And it really got me thinking about how, and this is kind of shifting more into like the OBGYN side of this conversation, about how I personally don't identify as a survivor of sexual trauma, but just my experience of prenatal care, actual labor and delivery, breastfeeding, all these things, how my experience might have been so different had I been identified as a survivor of sexual trauma. And so, you know, we know that for every 15 Black women who are raped, only one reports. And the maternity and the Black maternal mortality rate is still so high for Black women than it is for white women. And so, you know, what type of efforts do you all think, you know, medical staff can take to change these numbers? And why do you think these numbers are still, you know, are so high in 2021? Because I mean, that's we see a lot of people stopping themselves from maybe seeking treatment because they, you know, either don't feel comfortable in these spaces or, you know, and I know there's a huge issue for access too. But what do you all think?
That's what I was going to say.
I think you almost answered it, Abby, but y'all go ahead.
I agree with you, Abby, on that.
Yeah.
I think it's multifactorial. I think that there's a lot of different reasons out there, but in my experience, two of the top reasons are, of course, access to care, and then also a trust issue with the medical community entirely for African Americans. And I think that, and so that obviously goes into the higher mortality rate, and then also the, not just in medical, but reporting these cases of rape as well because of a trust issue with, you know, law enforcement and things like that. So I think there's a lot of reasons, but to me, I feel like those are the ones that I have seen before, you know?
Yeah.
I think that to me, kind of the underlying cause of both of those, though, is the repeated dismissal that Black women, you know, experience. And so this is what I try to teach my students is, why do we expect people to report if when they report, their report is dismissed and they don't see anything result from that?
And I think that's part of the trust issue, Candice. I mean, that they don't trust them because they're not listening to them. You know, if you're repeatedly not listened to, then why would you continue to do that, to go back, you know?
Right. Yeah. So I think that the reason that I try to emphasize that piece is because that leads to more of a system responsibility, you know, like as providers, it's our responsibility to fix that issue in the sense of listening to what people tell us and believing them. And that goes across not just trauma, but to me, maternal mortality, in the sense that, you know, you have to listen to what your patients are telling you and then believe them. And that leads to a whole set of different behaviors. But if you're just been repeatedly dismissed, we all just stop, you know, telling people, because what's the point? We haven't seen any change from that.
I think we need more of the patient advocacy as far as on the provider side and as far as nurses as well, because there is a huge health disparity among the African American or people of color the gap needs to be closed. Like you said, a lot of that has to deal with trust issues, and it comes from our checkered past that can't be denied. We're seeing that now with the vaccine. A lot of people are not going to get the vaccine because of the Tuskegee incident. Then you have, I don't know if people remember, you have the big incidents of the crack, where the government actually put the crack in the African American community. So it's a lot of other things that people are unfamiliar with in the Black community. And of course, with the police brutality and different things like that. So it's very deep in the African American community. So a lot of work that needs to be done.
Yeah, absolutely.
It's a huge, I mean, it's such a big issue and it goes back so long. And, you know, it's, you know, we have how many of you on this panel who are, you know, in this world and living this life every day, seeing patients or working towards seeing patients and students. And, you know, I'm wondering if, you know, like Amisha and Candice said, like maybe some of that gain and trust can start coming from those follow-ups that you all talked about, like, you know, and I was actually wondering if you all see more clients coming back for services or not waiting so long to seek services when they do have a problem, if they've received follow-ups from staff or they've like formed those close relationships. Hopefully that makes sense. So like, are you seeing people, I guess, pay more attention to their health if they've received those, you know, that kind of interpersonal follow-up care?
What I've seen on my end is a person is more willing to come back to you if you talk to them like a person. Yeah. And you explain to them on whatever educational level they're on, but not talk down to them. If you explain to them about their health and why you're doing different things, instead of just throwing medicine at them, they're more likely to trust you and to come back to you.
I've seen, like in the GYN world, just the non-judgmental. If they feel like they've come in and I've sat down and I've talked to them on their level and I haven't judged them and that they can be open and honest with me, then they come back, you know, in 2 weeks when they have another problem and they ask for me specifically, you know, and then in a month when they need something because they built that trust and they have felt that, you know, non-judgmental attitude towards them. And so they feel like they can come and they can tell me the truth about why they're really there and not, you know, kind of make up a problem and skirt around the issue.
Right. And we have a comment from Rashida. It said, absolutely listen to Black women specifically because the providers have to address and reconcile with the institutional discrimination within the medical field. And absolutely. And like Amisha said, like it's something we can't deny. And it's nothing we should deny. And again, you know, making that reconciliation maybe would kind of work towards, you know, seeing differences and what type of care specifically Black women and then also, you know, other women of color.
Well, and it's not going to be fixed overnight. You know, this is going to be a whole mindset, you know, culture change that we have to start teaching our young providers, you know, that this is important, you know, and that you know, different patients have different needs and that kind of thing. And I think that it's got to start in our young providers, you know, for it to finally get over that hump, you know?
Yeah.
Something that I really try to emphasize with my students and when I'm doing trainings is that trust is built over time. Mm-hmm. So a lot of times, you know, we as providers, we know our heart, we know that we're coming from a certain place to help, but the patients that we're serving don't know us, you know, especially at that initial meeting. So we should not expect people to trust us automatically. We should expect that we have to earn people's trust. And when you approach it that way, you're just so much less likely to get defensive, you know, about patient behavior. So I just want to echo what Ashley's saying is this is a process that takes a while to develop.
Right.
And I agree. And to the point about like training physicians, and I think the issue is that the system was broken and it was never meant for Black people in the beginning. Mm-hmm. And so we're training physicians and we're putting them out in this system was never meant to, you know, protect us and care for us in the first place. And so I think there just has to be like a complete culture shift in how, like it helps to train physicians, but if you train the physician and they're going to go out and their preceptors and their attending physicians don't have, you know, similar values and similar moral values or understand the issues that are facing like the Black community or other communities of color, then, I mean, you know, it's kind of just perpetuating a cycle. So I very much agree, but I also feel like we don't talk so much about, you know, how part of the system just needs to be dismantled, like, you know, from the bottom and build it from the ground up, you know, take into account, you know, those things that should be taken into account for communities of color. So.
Yeah. And I do have to say, I've actually experienced this firsthand. When I go to different doctors, I don't like to tell them my background, simply because I want to see how they treat me as a person without knowing my medical background. And I have experienced some doctors that came in, they would not touch me. I know I was clean. I looked appropriate. I'm always like that. But it's just how they treat you. And I know me, The doctor came in, he wouldn't even put his hand on me, but you're going to prescribe me some medicine. You haven't listened to my chest, my lungs, my heart, anything. You haven't even put your hands on me. I'm not coming back to you because you don't value me as a person. You value my money because you want to see me to get my money, but you don't value me as a person. So I'm not, and I wouldn't encourage anyone to go back to anyone like that because they don't care about you. And it's sad. And I did tell him when I left, I made him shake my hand and I told him my medical background. His whole attitude changed then. But that's unacceptable to me.
Too late. Yeah.
Yes,
Yeah.
way too late.
Mm-hmm.
I try to treat people how I would like to be treated or how I would like one of my family members to be treated. And I feel like if you do that, you cannot go wrong.
Mm-hmm.
Yeah. And thank you for sharing that, Amisha. I'm so sorry you have had that experience, and thank you for sharing that with us today. And I think Candice, you had said it, that it starts with a new generation or it doesn't start with, but adding a new generation of doctors that hopefully, take the same experience that Amisha had and never have that happen again. Like not, and then like Angela saying, dismantling past institutional ways of operating that just don't work or that were never meant to include certain groups of people. So thank you all so much for sharing your thoughts on that. And so and all this is obviously still combined. None of this is separated from each other, but kind of moving again more into like the labor and delivery side. But do you all find that pregnancy and childbirth can be triggering or re-traumatizing for survivors of sexual violence? Because, I think a lot of times we talk about how, being pregnant and having a baby can be this, wonderful, joyous moment and it's such an important part of your life, but it is hard. It is very hard. And it's not always just love and flowers and joy and smiling too. It's like, it's so hard on so many levels. And so I think we fail to talk about how, these events that are supposed to be really big moments can be triggering and re-traumatizing. So what do you all see in your work?
In pregnancy, yes, I've seen it be triggered. And like I said, we're not really screening that well in adults, and not even in pregnancy. I don't feel like we're screening that well for a history of sexual violence. And so I've seen where we might see them a few times for their OB appointments and everything is good. And then all of a sudden they come in and like their whole demeanor has changed and they're just a different person. And when you get down to it, it may not be the partner that they're with now, but it's a history of, and they've kind of buried it for all those years. And, they say maybe things like, I should be so happy right now, but I'm just not, and I don't know why it's causing me to feel this way. I don't know. And so it's really been eye-opening. Like I worked in labor and delivery as a nurse, but as a provider, to see it from the very beginning of pregnancy standpoint, to see the patients actually go through the pregnancy and, they can't usually tell me a specific trigger, but it's just at some point in that pregnancy, it comes up and then they feel the guilt because, and I try to tell them, Abby, I try to say, look, even, if you don't have a history of sexual violence or trauma or anything, like sometimes pregnancy just sucks. Like you're really sick, you're tired, you don't feel good. I mean, it's okay to not be excited all the time, but I think we do live in a world and in a culture and a Facebook world where it's supposed to be the balloons and you're super excited every day, and they don't know how to open up and how to deal with that, with the guilt that they feel.
And Daphne, like you said, I think that another issue kind of like that, which is not sexual violence, but it's traumatic, is miscarriages, and women don't talk about that either. And they, because all the flowers and the great pregnancy and all that, but it isn't for everyone. And women have a hard time even talking about miscarrying a baby for a multiple reasons. But I think that's very similar. They're like, I don't understand why I'm not happy about this, especially women that get pregnant after, miscarriage, and they it brings it all back up, and they're traumatized by that. So I think it's, both sexual violence and other traumatic situations affect, your pregnancy.
The women that I have worked with who had a sexual assault history have a very difficult relationship with their body, in the sense of, now I will say that these were women who had, PTSD level symptoms, but just any time that they had to pay attention to their body was incredibly distressing. And so think about how many changes your body is going through during pregnancy, and then in delivery, physical sensations that can be triggering. And so I definitely saw this a lot with women who, were seeing me while pregnant. And I agree with Daphne that they can't always put words to a particular trigger of what, brings those feelings up. But I will say a pattern that I kind of noticed was, if once they found out the sex of the baby, especially if they learned that they were having a daughter, that like hit women in a different way if they had a sexual assault history. And a lot of that stemmed from their fears about bringing a baby girl into this world, given what they know about the world. And so to me, a lot of, what I would do is just try to validate their feelings. Like you're all saying, this isn't all going to be sunshine and roses, and it makes sense why you feel this way. And we would talk about the cultural messages that they receive, and that just adds to the amount of guilt or shame that they would feel.
This particular question is not in the comments, but one of the therapists and I were kind of discussing this upcoming roundtable that we're having today. Laura, so shout out to Laura. She has asked, would a past of sexual trauma have anything to do or be directly correlated to postpartum depression?
Yes, so women, they're at higher risk for depression and anxiety, both during the pregnancy and postpartum. Okay. And so it's important to, again, this is why it's so helpful if the provider knows about that sexual assault history, because there is a lot that you can do to kind of prepare for these expected difficulties that they're going to face. And part of that is having a support system in place. If they have at least one person that they can talk to about how they're feeling, and it's in a non-judgmental environment, that just makes such a big difference.
And this is kind of jumping ahead, but kind of with that, is there anything you can change routinely when you're doing, or when there's like any type of routine checkup or prenatal care, or even during labor and delivery, that if someone is a survivor of sexual trauma, if you can change the way you do the exams or the checkups or anything like that to maybe try to avoid re-traumatizing? Or and I know we'd already talked about being vocal about what you're doing, like asking, is it okay if I touch you here, or this is what I'm going to do. And I know that they do that in sexual assault exams, that they're oftentimes very, they're going to tell you exactly what's being done before they do it, and making sure people know they can say no at any point. But what types of things that are kind of routine that have to be done, or, that can maybe be changed if a provider knows about these histories?
I think one thing that we do routinely in prenatal care, starting around 35, 36 weeks, and then also once, if they're being induced or spontaneous labor, so we do a lot of cervical checks. Yeah. And a lot of checking the cervix that isn't, not that it's not necessary, but we don't have to start doing that at 35, 36 weeks. If they're not having any problems and everything looks good, then we might push that out a little bit. If, maybe in labor and delivery, when they're in labor, if the baby looks good and mom's feeling good, we can space out the cervical checks. We can make sure, I know Angela will find this a lot probably when she starts her residency, or she's seen it a lot, like where a nurse will go in and check, and then 30 minutes later, the resident's around there, and everybody needs to practice, and the medical students need to practice, and the residents do, but like just communicating with each other and saying, hey, I'm going to do it now, but maybe like you can do the one in a couple of hours or whatever, to where we can be more in tune to that, to how often we're doing those things.
Right.
And just to add to that, so like as a student, sometimes we go to deliveries, or sometimes we're able to, deliver babies. And if, someone has a preference to not have like males in the room, or has a preference to not have, as many people in the room, then that means, of course, as a medical student, I'm like, okay, completely fine. I definitely understand. So just being mindful of like space and, who's in the room and stuff can also, is also something.
I think a lot of it goes back to a comment that Ashley had made earlier about trying to give the patient as much power and control as possible. So like Daphne said, there might be a lot of routine type care that's not necessary. And so giving that choice to the patient about how they want their care to go, and then respecting their decision, again, as much as is possible.
You all find that patients, feel like they'll be vocal about these things? Because I know, I even just thinking back to my past experiences with prenatal care and then labor and delivery, like I felt like I was well aware of what I could, what I could and could not consent to, and what things were routine versus what was optional. And there were still times when it's intimidating to really voice a preference. And so I'm just wondering if you all see people really having the confidence to voice when something is and isn't okay, or when they feel they can speak up.
I think that's when you really have to pay attention to your patient cues. Yes, there are definitely some patients that voice their opinion and tell you their preferences, which is great. But a lot won't. And you just see them shut down, and you're like, okay, let's look into this a little more. What are you uncomfortable? What's going on? Those kinds of things. So I think you just really have to read your patient a little bit when situations like that arise.
Yeah. Do you feel like most physicians do? Do you feel like most physicians read?
I think it depends. I feel like that's kind of been a perk for me, like as a med student. Like I don't seem as intimidating as like the doctor, and so like like I'll go in and talk to the patient, ask how they're doing, like is there anything they need, like just trying to be on their level. And like people have told me things that that they might not say to the doctor, just because I guess I don't seem as intimidating, which I hope I continue that, but yeah, so I think it just depends. Some women feel empowered to do that, some don't. And I think it's just like important to be mindful of that, and to try to give as much as autonomy to all patients as you can.
Right.
Angela, you're so right about, I'm sorry, Candice.
I was just going to say, in an ideal world, that's why to me, it's so important to start these conversations early, like during those prenatal visits, to where the patient has multiple opportunities to vocalize their desires and preferences, because sometimes, their first interaction with you, they're not comfortable enough to have this conversation. But again, trust is built over time. And so the more contact that you have and the more opportunities they have to build up that confidence to vocalize what they want, the better.
I think also, as an instructor at a teaching hospital, I always want my students to get the best opportunities and to see everything they can, but I have to remind myself too, like, this is the patient's experience. And so I always make, me and my student go in well before delivery if we can, and go in there multiple times and introduce ourselves and try to start building that trust and pick up on patient cues, because I don't want them, when their legs are up in stirrups and they're about to give birth, to all of a sudden a sea of, students come in and line up. Like I told my students up front, like, you're not going to do that, and if the patient says no students, it's just no students. Or if they say no males, it's just no males. Like, this is their experience and we're respecting it. And we don't know their past. We don't know their history. We don't know. And so I think just being very, very mindful of, I'm nursing, but there's also medical students there. There's also, CRNA students there. There's EMT students. There's a lot of people. And so be mindful of the entire room and read each other's cues. But the patient, the patient will usually tell the nurse before they will anybody else. And I think it's really important as the nurse to, in the beginning, say, okay, there's going to be these people in here. Do you have any preference? Are you okay with that? You can tell me. You're not going to get, you're not going to get in trouble. We're not going to treat you any differently.
I think you're right, Daphne, about about having the trust, with the nurse. That always used to happen when I was a nurse in the hospital. I would walk out and I'll be like, to the doctor, the provider, whoever, I'm like, did you hear about this? And they're like, what? No, I talked to her for an hour. How did you find that out? And it's just because I'm in there, hey, are you okay? Do you understand that? And all of a sudden out of nowhere, out of left field, something, comes out. So I think that relationship with the patient is so important. And then also what you're talking about in the, labor and delivery room is similar to other experiences too, where, your patients aren't a protocol or, this is an ear infection. It's kind of like, when you're working in the ER and you're like, ear infection in room 3, such and such in room 4 or whatever, it's not an ear infection. It's not a stomach bug. It's not a patient delivering a baby. It's a person. So, and they have all of these things going on, with them. And that's just so important to know. It's like you were saying, all these students are there. Okay, the baby's about to come. Okay, well, we forgot that this may be the mom's first baby, or she may be super modest because of something happened in her past. It's not that experience for the student. It's first the patient, and so I think that's really important to remember too, like you said, Daphne.
Thank you all so much. And I know and I don't know how much time we have. Kelsey, are we?
We're good.
We're good? Okay.
Yeah.
Cool. Okay. Y'all are wonderful. I love this so much. I appreciate it so much. And so, we've talked a lot about kind of leading, prenatal stuff, different, medical stuff that's not just related to OBGYN care or pregnancy, labor and delivery, but what about breastfeeding, and obviously breastfeeding, however you choose, breastfeeding formula combination, you do what you feel most comfortable with and what you feel most successful with for you and your baby. But I do know that breastfeeding is it's a very intimate act, and it's very time consuming and it's very tiring. And, I can just speak personally, I'm a very, I love hugs. I love affection, but there are times that I'm like, I have been nursing for hours and I just need space. And so, again, with a survivor of sexual assault, and oftentimes this breastfeeding, this is coming after you've seen the doctor. You're home, you're on your own. And, sometimes you don't have an outlet, for somebody to talk to. So, what do you all see with the success rate of maybe breastfeeding for sexual assault survivors, if you know that information, or just kind of information around that?
It is definitely noted as a challenge. When we look at the literature, I will say that there's not a ton of research that's done on this topic, but what is out there, surprisingly, what is out there shows that women who have a sexual assault history are more likely to struggle with breastfeeding. And in my work, again, I work more with providers than with patients, but I try to help providers understand that, because there is such a push to get women breastfeeding, and there's a big stigma against women who don't breastfeed. And so again, my message is more, how can we have compassion for why women might be struggling to breastfeed or just flat out refuse to? Again, it goes back to that just difficulty connecting with the body.
Right. Yeah. Sorry, I was giving time see if anybody else. But yeah, it would be interesting to see if there was more research on breastfeeding with sexual assault survivors. Because that's definitely a time, like I said, when you really feel like you're on your own, and And Candice, like you said, there is still a lot of stigma around, women who choose not to breastfeed for whatever reason. And that can be really hard. So kind of getting towards like wrapping up, what are things that you wish people knew about your field or your work that you don't often get to share?
I probably have the least to comment on that just yet. If you guys want to know something about medical school.
But you have a huge advantage because you're a rape crisis advocate as well. So you already have a totally different perspective. So that's great.
That's true.
Yeah.
I think something that people probably don't know about providers is that, they think, oh gosh, they're so busy. They probably have, hundreds of patients and they don't remember, about that. But I'm speaking for myself, but I know a lot of people that are providers and they do the same thing. We take a lot of it home. We just take a lot of it home with us because we really do care about, I think people in this role truly care about other people and connect with other people and care about that connection. And so when something is wrong with the patient that I'm working on and I'm like, oh gosh, what am I going to do about this? I do take it home. Like I sit at home, like in my bed at night thinking, okay, what could I do for that? Because it didn't get better this time, just things like that. Or if they're sad or something didn't go well for them or the treatment didn't work or it made them sick or any of those things, we do take it home with us. So it's not, you're not just a number or just a medical chart number. It really is, to me, it's a connection. So I don't think that everybody knows that about their providers.
Yeah, I would say for the majority of the providers, they want to, like you say, do their best, and they do take it home if they care about their clients, and the clients tend to become more family than clients if they truly care about them. But there is a certain small percentage that don't. Like I said, I have experienced that, but I would say the majority of the providers, the large majority of the providers do care about their clients and want the best for them.
I would say from my perspective, I find myself talking to a lot of people about trauma that probably previously had no interest or thought about that topic. And so it can sometimes feel like an uphill battle to convince people that that's an important topic. So I guess that would just be my thing that I wish people understood about the field that I come from is, again, if you are interacting with other human beings in any type of social service system, you're interacting with trauma survivors. And the more that you can begin to see that as part of the people that you're working with and understand their behavior in a different way, it's not just about increasing the care that you give to other people, but you are going to be more satisfied in your role as well. Because once you start interacting with people in that way, they react to you differently as well. So I really try to emphasize that this is not just for the benefit of the patients or the clients that you're working with. This can also benefit you in your job.
Absolutely.
Yeah. Well, I do want to also bring up what's the greatest joy in your field, and this will kind of help wrap us up.
Yeah.
Because you got to end on a high.
Yeah, right.
And obviously, there's still so much work to be done in all the aspects of this conversation. And so let's end on a happy note, or as happy as we can be. What are your greatest joys in what you do?
I think it's just the relationships that you build. Like, Ashley said, we provide care and we want people to know that we truly care. We look at them as family. And so from the OBGYN standpoint, we're there with them maybe from the time they're a teenager and they first become sexually active. And now, now they're pregnant with their first child. And then we go through pregnancy and we go through postpartum, and we might go through postpartum depression with them. We're there for the highs, we're there for the lows, and they become family and for the entire team that they're with. And that's why we do what we do. It's not that they just come in and they're not just a number to us. Like, we want to be there for them.
So
Yeah, that's wonderful.
That's what I'm looking forward to the most, I'd say, is, the ability to, and, the opportunity. It's like such an opportunity and honor to, have someone trust you in that capacity, to make you a part of their family and to be with them through some of the most vulnerable times in their life. And I'd also say, there's just so much to like learn, and so many opportunities to grow. Like, I feel like I've learned so much just being here today, and listening to y'all. So thank y'all so much. So
You're going to be amazing, Angela.
oh, she is.
Yes.
So good luck to you, and congratulations on your match.
Okay.
Yeah. Well, anybody else?
I don't get to interact. Oh, go ahead, please.
I would say the high that I get is seeing the changes in my clients. Like I said, I'm family, so I see like hypertension, diabetes, thyroid, everything like that. So to have a client come in and say, no one has been able to control my diabetes, and their A1C is 14 and I get them down to a 6, I'm like ecstatic. And they're like, thank you. And I'm like, thank you for trusting me, so that's where I get my highs. I love to see the changes and the positive. Of course, we do see a lot of negatives, but that make my day, and that keeps me going.
I don't get to interact like with direct patient care as much as I used to. So I had to kind of get my joy from somewhere else. And I've realized that I still get that from the trainings that I do, because inevitably at least one, but usually more people kind of hang back after the end and come up and share a personal story that they might have, or how a piece of what I talked about resonated with them, and to have someone else, put words to their experience. Again, it goes back to that direct, that connection that you get to form with people, and the moments when you feel like your work has made a difference, because the work that we do is challenging. And so those, you have to hold on to those.
Absolutely.
Well, thank you all so much. I feel like we could have like 100 more of these roundtables based off of like every little bit that we talked about, and I appreciate you all so much for taking the time out of your day to share your experiences and your knowledge and your wisdom, and just everything. We truly appreciate you, and thank you.
Absolutely. And for those of you who are watching, yes, this is National Sexual Assault Awareness Month and National Child Abuse Awareness Month. And we've had some very powerful conversations, over this month, but we do not want these conversations to stop. Yes, they can be very uncomfortable, but they are very necessary. So for those of you who are watching now and that may view this video later, please know that you have access to 24/7 advocacy. So if you are in the Mobile, Clark, or Washington County area, if you know someone who has been affected by sexual violence, or you have been affected by sexual violence, our crisis hotline number is 251-473-7273. But if you are not in either one of those counties, please don't let that stop you. So if you are out of the area, that number is 1-800-718-7273. Please do not continue to suffer in silence. Know that there are people who are in your corner that are always ready to support you. All right, so thank you all so much again, and thank you to those of you who have joined in the conversation today. So thank you so much. Take care.
Thank you.
Thanks, everyone.
Bye-bye.